Hello, my name is Priscilla Sano and I am with Grand Canyon University, and today's topic will be on RAAS and its effect on blood pressure. In today's objectives, we will be taking a closer look at what RAAS is, which is the renin-angiotensin-aldosterone system, cells that help to increase renin secretion, the outcome of renin secretion, RAAS in action, angiotensin II in action, aldosterone, and aldosterone in action, the final stages of RAAS, when RAAS goes awry, and medications that help to reverse the effects of RAAS. RAAS, as stated previously, is the renin-angiotensin-aldosterone system, and it is a system that can increase blood pressure for the long term. The juxtaglomerular apparatus has granular cells that cause the release of renin, and this is what renin looks like molecularly. Renin is an enzymatic hormone. Renin will also be released under certain conditions, such as a decrease in sodium chloride, a decrease in extracellular fluid volume, and or a decrease in arterial blood pressure. The macula densa cells also assist with autoregulation. There are cells that help to increase renin secretion. First and foremost are the granular cells located within this section. The granular cells are intrarenal baroreceptors, and they detect afferent arterial pressure. So when blood pressure decreases, they are going to release more renin into circulation. The macula densa cells are located right in this section, and they detect decreases in sodium chloride moving past them through the tubular lumen. So these cells will respond by releasing more renin in response to this decrease. The sympathetic nervous system is connected to the granular cells, and as blood pressure decreases, the baroreceptor reflex causes the sympathetic system to influence the granular cells to release more renin. So all of these situations will help to increase renin being released into the bloodstream, and that'll ultimately help with the increase of blood pressure. Outcome of renin secretion: sodium ion reabsorption will be increased by the distal and collecting tubules of the kidneys, and this will be followed by water retention. So these two factors will ultimately help the plasma volume expand to increase arterial pressure. RAAS in action. So what will ultimately trigger RAAS is a decrease in blood pressure. So as blood pressure decreases, it will go ahead and stimulate the kidney to release renin. And remember, renin is an enzymatic hormone. Now, angiotensinogen is made in the liver, and it's going to be found in high concentrations normally in the plasma. So as renin and angiotensinogen come into contact, renin, being an enzymatic hormone, will go ahead and cleave angiotensinogen into angiotensin I. Angiotensin I will now travel in the blood, and it will venture into the lungs eventually through the pulmonary circulation. And here it will make contact with another enzyme, and this is called ACE. ACE stands for angiotensin converting enzyme. So as ACE and angiotensin I come together in blood, that will go ahead and cleave angiotensin I into angiotensin II. Angiotensin II in action. So angiotensin II will bind to receptors called AT1 receptors on the surface of vascular endothelium, causing vasoconstriction. It will help the proximal convoluted tubules of the kidneys with sodium reabsorption, and therefore it'll help to retain water. Okay, so we can see that here, and we can see the constriction of the blood vessel. It will also stimulate the adrenal cortex to release aldosterone, and as aldosterone is increased, it'll promote sodium reabsorption and water retention as well. Angiotensin II will stimulate the hypothalamus to stimulate thirst within an individual. So the person is well aware that they are thirsty and they will go ahead and increase their water intake to help with this whole process. It will stimulate the posterior pituitary gland to release antidiuretic hormone. An antidiuretic hormone is also known as vasopressin. And the whole function of vasopressin is to increase water being held instead of being excreted by the kidneys. Thirst and water retention due to vasopressin lead to the plasma volume expansion, and it reduces the baroflex response to increase blood pressure as well. Aldosterone. So the distal and collecting tubules of the kidney have cells that are called principal cells, and these cells are influenced directly by aldosterone and vasopressin. So as aldosterone is increased in circulation, it will cause the sodium ions to be reabsorbed in the distal tubules, and with that, water will also be reabsorbed. And as that is occurring, potassium ions will be excreted. Now, vasopressin will end up inserting aquaporins into the nephron collecting duct cells, and that will cause these cells to reabsorb water into the blood. Aldosterone in action. So aldosterone causes there to be an increase of sodium leak channels in the luminal membranes and the sodium-potassium pumps in the basolateral membranes of the principal cells. So as that happens, more sodium will flow into the distal and collecting tubules from the lumen. There will be an increase of sodium out of the cells into the plasma. And the increase in sodium reabsorption will also cause water retention. So at the end of it all, arterial blood pressure will end up increasing. In the final stages of RAAS, blood volume and blood pressure will ultimately increase due to all of these actions taking place. So instead of our blood pressure being at a low level, it will come back to a normal state. And the kidneys will end up having a negative feedback system for RAAS. So since everything is brought back to normal, it will go ahead and send a signal letting the kidney know to stop the release of renin as it is no longer needed. Now there are times where RAAS can go awry. So if there is something causing RAAS to increase abnormally, hypertension or high blood pressure will ensue. So there can be things as a decrease in blood pressure due to a failing kidney or failing heart instead of a decrease in just the sodium ions, and that will cause RAAS to become activated. This can lead to an abnormal increase in blood volume and an increase in sodium retention, causing an elevated blood pressure. Now, there are medications that help to reverse the effects of RAAS in these situations. So diuretics will end up promoting water loss. And since water loss is promoted, it will promote sodium ion loss, reducing extracellular fluid and blood pressure. Now, the ACE inhibitors are very important as well. So ACE inhibitors will prevent angiotensin 1 from becoming angiotensin 2. And angiotensin 2 does cause a lot of these factors to help it to increase blood pressure. Whereas in this situation, we don't need it to be increased because it is already abnormally increased. The aldosterone inhibitors will prevent sodium channels being inserted in the kidney so that sodium reabsorption does not occur. And other aldosterone inhibitors block the already present sodium channels. Decreasing angiotensin 2 will lead to a decreased sodium and water reabsorption. So at the end of it all, blood volume decreases and the reduced pressure on the arterioles reduces blood pressure. In review, today we have talked about what RAAS is, which is the renin-angiotensin-aldosterone system. We have talked about the cells that help to increase renin secretion, what happens as renin is secreted, what RAAS does, angiotensin 2 and its actions, aldosterone and aldosterone and its action, what happens in the final stages of RAAS, when RAAS goes away, and medications that are ultimately used to combat the effects of RAAS due to the effects of hypertension. I hope you have enjoyed today's presentation. Thank you very much and have a great day.